So I know you were saying that you call NT-proBNP and send them to you, but I think in some parts of the country, the pathway doesn't seem to work as well, that, the symptoms are ignored and patients don't even get an NT-proBNP or an echo or be referred. And there seems to be this sort of, I guess a lack of urgency for early identification of them. And then these are the current guidelines. So you'll be aware of ESC recommending SGLT2 inhibitors for HFrEF. And then the American guidelines, I don't know how familiar you are with them.
I'm also a fellow of American College of Cardiology. So I was also briefly in US as well.
So you know them. Okay. So you know that obviously they came out after some more data came out with SGLT2 inhibitors. I mean, before Deliver, but after some of the other trials. So they actually have the recommendations for MREF and for PEF. Now, you'll know DAPA-HF in a lot of detail, so I won't go over this, except to point out a couple of similarities between DAPA-HF and Deliver. So the same primary endpoint was used: CV death, hospitalization for heart failure, or urgent heart failure visit. Quite similar inclusion criteria apart from the ejection fraction. So, in terms of EGFR, DAPA-HF was over 30, Deliver, as we'll see in a minute, was EGFR over 25, elevated NT-proBNP, type 1 diabetics excluded, and so on. And obviously 1-to-1 DAPA to placebo. And a number of similar endpoints in terms of the secondary endpoints, which we'll come to in a minute. So a lot of comorbidities in DAPA-HF. You've got half of patients with type 2 diabetes, about 40% with some sort of a kidney dysfunction. So you were talking about, what do the nephrologists think? I guess a lot of these comorbidities, they all happen at the same time, don't they? You've got someone whose heart is not working, as well as their kidneys, as well as a multitude of other things. And these were results from DAPA-HF, on the basis of which there is the license in HFrEF. And then we come to the new part, which is the Deliver study. So a larger study, over 6,000 patients, as you will have seen, ejection fraction over 40. So it's MREF and PEF. And they had to have evidence of structural heart disease. Now, I've mentioned the primary point is exactly the same. And there are some secondary points as well, including looking at symptoms using KCCQ. And again, you've got about half of patients that have type 2 diabetes, around half with some sort of a kidney dysfunction. There was about 90% of patients that had hypertension, so a lot of comorbidities. A couple of differences between Deliver and DAPA-HF. They allowed patients that were hospitalized or recently discharged, so within the last 30 days, to be enrolled. Now, that's a group that tends to be excluded from clinical trials because they tend to happen in patients that are, outpatients that have been stable on their medications for a while. So, for example, in DAPA-HF, they had to be stable on their medications for a good while before they were enrolled into the study. But in Deliver, they wanted to have a look at these patients that are in hospital. And there is a paper published that looks specifically at this subgroup, this 10% of patients, to see if there's any difference. And there's not. I won't spoil it for you, but they're consistent with the other ones. And the other subgroup to point out is this, they call them HFrEF. Is that something you...
Yeah, that's what I was telling about.
Yeah.
Because a lot of research is also happening on that group, in fact, because it is a little bit, not really new, but a little bit new. And a lot of data is emerging for that. And there are a lot of curious questions as well. And another thing, if I may add, if I really recall well, yes, indeed, you said it, like we tend to use SGLT2 inhibitors were initially indicated only if the LV ejection fraction is more than 40, less than 40. However, if in mid 2021, was there some change as well in the indication, like it need not be really always less than 40. So even if it is a little bit higher, still SGLT2 inhibitors that may be used.
So there was some data that came out. So there was data with EMPA and their study, which was the Emperor Preserved, which in a way was similar to Deliver, where patients had an ejection fraction of above 40%, and that trial showed benefits. So I guess some people, and now there is a license, of course, for EMPA in that space, and some people will, start using EMPA. There's no reimbursement yet, but there is a license, so of course they can do that. There was also a smaller study with sotagliflozin, which was a different kind of study, but again, it included some patients that had HFpEF, and it showed consistency with the overall results, which were positive. So, on the basis of both of those, the American guidelines recommended SGLT2 inhibitors in HFmrEF and HFpEF.
So the question still remains the same. So is it advice or not?
So with DAPA, there's no license in ejection fraction above 40%. With EMPA, there is a license for any patients with chronic heart failure.
All right, irrespective of the ejection fraction.
Yeah.
Okay.
Yeah.
Thank you.
Because they have two trials. They have their EMPA Reduced, which is ejection fraction less than 40. They have EMPA Preserved, which is ejection fraction above 40. Both trials positive. So the license is now here in the UK. You can use them. The other agent that I mentioned, SOTA, I believe is not available in the UK. So
right.
Just for completeness of the picture, I guess.
So EMPA, yes, for all the others and all as well, but DAPA only for if less than 40.
Less than 40, yeah. That's what the license currently is, yeah.
Oh, absolutely.
So this is the Deliver data, which is off license. It, as you would have seen, only came out at ESC, so it's pretty new. And the license is always behind the data, isn't it? I have to wait a little bit. So primary endpoint, you would have seen a reduction, 18% relative risk or 3.1% absolute risk. Then here which numbers you prefer, and highly statistically significant. And then this endpoint, if you split it out into its component, a numerical reduction in CV death, but not statistically significant, and then reduction in both hospitalization for heart failure, which is significant, a large number of events, and a smaller reduction in urgent heart failure because it's not significant, very small number of events. So that's your primary endpoint. And the primary endpoint is consistent across the ejection fractions. So they looked at ejection fractions split out into the three groups, so nearly sort of equal groups. Doesn't seem to be any difference. They tested it with a p-value for heterogeneity, which showed no difference between the three groups. And they also, in the paper, looked at it as a continuous variable. You know, those graphs that they do where they have ejection fraction along the bottom and hazard ratio, and they plot hazard ratio at any point, and the line is pretty much horizontal. So there's no difference by ejection fraction with DAPA. And your group HFmrEF, again, they are consistent. So if a patient had had a prior ejection fraction of less than 40%, then they improved and they were in the study, they saw the same benefit as the patients who have always had an ejection fraction above 40%.
Yeah.
And then you asked me about safety. So they looked at specific adverse events. So volume depletion was balanced. You can see both studies there, the DAPA-HF and the Deliver. So no difference in volume depletion or renal adverse events. Major hypoglycemia, we've talked a little bit about. Again, no difference between DAPA and placebo. DKA, a small number of events, 2 in DAPA and none in placebo.
Was there any p-value analysis as well?
So I haven't seen a p-value for this analysis yet. It's in the, as they publish it in the New England of Journal, they don't tend to put the p-values on. as you know, but in the main body of the text, they comment that there's no difference between the two groups. But I haven't seen p-values for this.
So statistically, we are not aware that is it significant or not.
So it seems to be, from what they're saying in the study text, it's no difference. So statistically not significant. So you might say, for example, numerically there's a few more volume depletions with DAPA than placebo, but it's not statistically significant. We have that data for DAPA-HF. We have all the p-values, but I haven't seen it for DELIVER yet. I imagine one of the papers that comes soon might do.
What do you think what is the reason for the fracture in this subgroup of patients? Is it secondary just for the heart failure? Is it due to some of the medications, or is it something else?
So the fractures was a signal that was originally seen with one of the other SGLT2 inhibitors, where they saw more fractures and more amputations with canagliflozin in the CANVAS study. So all studies now have to look at, whether there's any imbalance. And now I don't think that the current thinking is that it's anything to do with the medications, but it's just something that, has been noticed and has to be looked at. I don't think there's any, mechanism that has been proposed for either fractures or amputations as to why, or how these agents could cause it. But, again, it has to be looked at. Whereas, major hypoglycemia, we know that if you have, two diabetic agents, especially if one of them is a sulfonylurea or insulin, you add another one in, you could tip someone into hypoglycemia. And DKA, there is a mechanism for how that happens. But my understanding is that fractures and amputations is just something that has to be looked at, but it's not sort of a mechanism. Mm-hmm. And you can see, for fractures in DAPA-HF 49 and 50, not even recorded in DELIVER, so I don't think it's much interest now.
Right.
Is that okay?
Yeah. Thank you.
Summary?
No, this is very, very useful, in fact.
But DELIVER in about 5 slides. Not death by slides.
Impactful. That's pretty impactful. And for example, if we come across a patient with heart failure with preserved ejection fraction, so where do the evidence, for example, stand right now?
In terms of the SGLT2 inhibitors?
Yes, yeah.
So you have evidence in dapagliflozin with the DELIVER trial, which, the evidence is there, the license is not. You have evidence and license for EMPA.
Yeah.
And that's it. There's no data for CANA. There's no data for any of the other ones. So it really is just EMPA has data and license. DAPA has data, not license yet. If your question, I guess, is more around comparing the trials, well,
yes,
it's very okay. It's very difficult to do, isn't it? How do you take two trials and compare them where they might have slightly different inclusion and exclusion criteria, and they might be, slightly different in terms of their patient baseline characteristics? I do have a slide somewhere on the baseline characteristics. I think they're pretty similar between the DELIVER and the EMPEROR preserved. And then the primary endpoint, the sort of the hazard ratios are fairly comparable between the two trials. The only difference that seems to be is if you take the DELIVER data and you combine it with the DAPA-HF data in a pooled analysis, which is what they did. I don't know if you saw that presentation. So that was a pre-planned patient level analysis of the two trials. They actually saw a benefit for cardiovascular death if you combine the two.
Yeah.
Now with the EMPEROR trials, EMPEROR reduce saw a reduction in cardiovascular death. So if you put the two trials together, there's no sort of signal there. So that's probably kind of the only difference. And then, the other thing, as we mentioned, the fact that they had recently hospitalized patients in DELIVER, so that's a little bit of data there. Having the patients with improved ejection fraction, again, that was excluded from the other trials. So kind of evidence in some of the gaps that were previously existing, I guess.
And another thing as well, so if there is any acute heart failure patient which is admitted, is there any data as well, like which among the SGLT2 inhibitors tend to have a favorable outcome?
So there's no study that compares the SGLT2 inhibitors. With EMPA, there is a study where they looked at about 500 patients with acute heart failure. Now, this was any ejection fraction, and they saw a benefit for the primary endpoint, which was this slightly complicated composite, but essentially, did their heart failure worsen? Were their symptoms better? Did they die? To summarize it, I can find the actual description for you. And so they saw a benefit there and then no differences in the adverse events. With DAPA, there is this sub-analysis from DELIVER, which looks at these patients. So they call them subacute. There's 10% of patients that, are either hospitalized or within 30 days, and they see a consistent benefit in that group compared to the overall population. And again, no difference in safety. And there is a big study with about 2,000 patients that's ongoing, specifically in patients that are hospitalized with acute heart failure with DAPA. That's going to report at some point next year. And that's looking at, hospitalization for heart failure, cardiovascular death, safety, and so on. So I guess in acute heart failure, it's limited data because a lot of the big trials tend to exclude those patients. So then you either have sort of standalone trials that are not as big looking at that group, or they try to include them from the big trials like DELIVER. So I guess if your question is around efficacy, it seems to be working, and safety seems to be consistent, but there's not as much data in those patients as there is in the outpatient population.
Right. Thank you.
Does that answer your question?
Absolutely. Thank you.
I realize I've taken up quite a lot of your time.
No,
Is
this
there
is
anything else you want to say?
so. Right now, for example, if on an academic basis, I'm asking. So if there's a patient of heart failure with reduced ejection fraction, if it is coming,
Yeah.
among all the newer medications which is approved, I would say in the last decade, I would say at the most, which one seems to be having the strongest data, favorable data, for example, for a reduced one, for a preserved one, or like that?
So I think for reduced ejection fraction, among the SGLT2 inhibitors, you have DAPA and EMPA. Again, quite hard to compare because they are quite consistent. In DAPA-HF, there was a reduction in mortality.
I mean to also include also the ARNI inhibitors.
Yeah, so ARNI inhibitors, so you've got obviously the Paradigm trial, which saw a reduction in the primary endpoint. It seems to be with, if we're thinking about, the spectrum of ejection fractions, that with ARNI, there is some sort of attenuation. So if you remember the Paragon trial, then that wasn't significant. And then some sub-analysis seem to say, where's that cutoff point? Is it around 45? Is it 50 something? Where you have a benefit lower down, but then you don't. This attenuation doesn't seem to be seen with DAPA. And in fact, I've got quite a nice slide to show that. So this is from the pooled analysis. So hospitalization for heart failure or cardiovascular death as an endpoint, which is used a lot in a lot of the other studies, looking across the two studies and looking across the ejection fraction, there doesn't seem to be any difference in effect, which, seems to be different to the other agents, as I say, with sacubitril valsartan, you seem to see that attenuation, and, with the other agents as well that are older, they don't seem to work as well in PEF as they do in REF. So that's something. But I mean, it's very difficult to compare head to head unless you have a study that, has 4 arms and puts, patients on specific drugs and compares them. It's hard to know how do you answer that.